Welcome to the Tennessee Heart Health Network webinar. Our aim is to be your resource for innovative statewide initiatives to improve primary care for all Tennesseans. We hope that you enjoy today's educational program and share it with your colleagues to make a better impact of heart health in Tennessee.
Hi, everybody. I'm Ashley Ellis, and I'm a pharmacist. I'm Assistant Dean for Strategic Partnerships and Innovation, and I also work with the Tennessee Population Health Consortium and with the Tennessee Heart Health Network, especially with helping to develop our physician-pharmacist collaboration. And I'm really excited today to welcome our guest, Dr. Jonathan Hughes, who's also a pharmacist, and he's going to be talking to us today about pharmacist billing and credentialing and his process through that. He has really walked through that quite a bit in the state of Tennessee. And so this is going to be part of our track here. And I know everybody's really interested to hear more about that and to have this as part of our enduring material. So welcome, Jonathan. And I'd like for you to introduce yourself if you could.
Yeah, absolutely. Thank you for having me. My name is Jonathan Hughes. I wear a few different hats at my practice site. I work for Ascension St. Thomas, and within Ascension St. Thomas, I'm still in clinical practice as an ambulatory care pharmacist. So I do that 2 days a week. My practice site is the St. Louise Family Medicine Center in Murfreesboro, Tennessee. I'm also the residency program director for our PGY2 ambulatory care pharmacy residency. And then finally, most recently, I've served as our manager for our ambulatory care pharmacy service line.
Excellent. Okay, great. And so how long have you worked in ambulatory care pharmacy itself?
Yeah, so I have been in ambulatory care pharmacy, if you count residency years, 9 years.
9 years.
And then post-residency, 7.
Okay. All right. So how did you kind of become interested in that billing side, the payment issues? I know all of us who've kind of worked in primary care that we have to be having conversations about justifying our services and our positions quite a bit. But how did that pique your interest? Was that originally, or did it come over time?
I think it was a product of how I grew up, so to speak, within residency. I did my residency with the VA. And kind of getting to learn from some great masters within the VA about all these wonderful services that we can provide as ambulatory care pharmacists. I was really surprised to not see that outside the VA so much. You know, you have little peaks and, a little windows into really advanced innovative practices, but just seeing that as a common part of primary care and outpatient care in the US, it kind of puzzled me why that wasn't there. So, the first question is, well, maybe there wasn't enough data to support it. Maybe the solution was that we needed to come up with capturing the clinical impact. But as I continued in my residency, it hit me that we've got 2 decades, if not more, of data showing the impact, going all the way back to things like the Asheville Project. And so what I realized as I got out of residency training was that it wasn't really the lack of clinical data showing the impact of a pharmacist. It wasn't other disciplines not knowing what we do, although that still is sometimes a barrier. The major impact of not seeing ambulatory care pharmacists as part of the U.S. healthcare system is a lack of a payment structure in order to have a cost-justified practice model. And so that's really one of the drivers for my interest in this, is to say, if I really believe in this profession that I'm a part of and the impact it can have, how can I help overcome this major barrier to our health system?
I'm right there with you, and I think we kind of have come up about the same time, I think. And when I first got out of residency, I had a lot of those same conversations. At first, it was what would a pharmacist do in my clinic, and now it's I want a pharmacist in my clinic, right? But how do I pay for it? So that's kind of where we find ourselves. So what have you learned specifically really about some just high level federal regulations and state regulations here in Tennessee that have been helpful to you in your practice, have supported your practice, and have made a difference?
Absolutely. And, this conversation could go 100 different ways, and I'm excited to explore all of them. So just depending on where I go, let me know if you want to redirect it one direction or the other. I think one of the big things I've learned is how complex it is and how underprepared we are when we graduate pharmacy school for understanding the ecosystem of how healthcare economics works. So I think your initial question contained like differences between federal and state. That's part of the complexity. Is that living in America, we have two tiers of governance and regulations that impact healthcare, and one of those is the federal, and one of those is the state side. I think I've ended residency or graduated from residency as a very fortuitous time at the state level, when in Tennessee we had just passed the 2017 Pharmacists as Providers Act, which prohibited state level insurers from discriminating against pharmacists on the basis of licensure. However, which has been a great thing. It's had many barriers to overcome in the actual implementation of that. However, if you don't understand that there are also federal regulations that impact probably one of the biggest payers that pharmacists will see and their patients will have, being Medicare, you're going to not count the cost, so to speak, and moving forward in your practice. You have to understand those differences between those major payers and what you can do over here and what you can't do over here.
Yeah, definitely. And I've had a lot of conversations, especially when I was starting out in primary care. I know you've probably heard that too, where I would suggest services, I would bring it up from ASHP, APHA documentation, other people are doing this, and then I would hear, well, we can't do that. And then kind of my response to it would be, is it that we can't do it, or that you haven't done it before, or you don't know how to do it? I mean, have you encountered that, and what are some of your best practices on how to overcome those barriers?
Absolutely. We were just at a summit this past week where I heard several health system pharmacy leaders say that their administration had decided that it wasn't worth the squeeze. The juice wasn't worth the squeeze. And I think that there were some folks in our administration who had those concerns and really wanted to see the pharmacy clinical practice model succeed before they went down that route. But I feel like in that regard, I've been blessed to have administrators who have seen the vision, who've caught the vision, and to understand that. So I don't want to take full credit for that. I want to give a lot of that credit back to my senior leaders in being receptive to that. But I think for those who are a little bit more hesitant, some of the keys was first establishing the clinical practice model internally. It's one thing to come and show external metrics, and that has value, but to show that, hey, this actually can work if you'll give this a try. This can have these benefits both to patients, then to providers. Your providers, your physicians, your APPs, they become some of your biggest champions and stakeholders in these practice models. And then trying to translate that into how can you have that more? You've done this test in this one clinic and you've got this handful of people who are just singing the praises and telling you about the successes that are coming. Well, why wouldn't we want that in our other clinics? Well, to make that happen, we're either going to have to invest $1 million every year, or we're going to have to come up with a way to cost justify that. And here's our different levers that we can pull for cost justification. Here's the pros and cons of each one. And this is why I think we should go forward with this model, with the billing model. And I think maybe this can also be a context for the interview as a whole. I think that's an area that I have a lot of experience in the model, is in the billing aspect of that.
Mm-hmm.
However, I don't think that you should think of it as an all or nothing, that you're
Right.
all billing or and no value-based care, or all value-based care and no billing. I think it's probably most effective to spread your eggs out into multiple baskets, so to speak, to have a hybrid model, and that's certainly what we pursue within my practice.
I agree with you 100%. I think that I've learned, I'm sure we all have had stumbles where you're like, I wish I learned that earlier. But I think when I first started out, I really did a lot of MTM. And then that has changed so much from back when I started back in 2007. for the ability to count on that revenue, and the ability of who can provide it. And so when I had all of my eggs in that one basket, and then that changes, I think you're right. To have multiple different streams of services delivered very, very well is a great way to have a stable practice and a stable clinical pharmacy staff. I think you're totally right on that. All right, so let's talk a little bit about your credentialing and contracting process, which is a little bit of that nitty gritty. And it can feel overwhelming to a lot of people. And like you mentioned, some of us never learned anything about this in pharmacy school. And I think the things I learned about billing, coding, I always say the reason I learned it is because I wanted to have a job. It's not necessarily something I learned in pharmacy school, but you talked a little bit about the provider parity legislation and what that means for Tennessee pharmacists. Can you speak a little bit more specifically about that and how pharmacists can use that to expand the services in their own clinics?
Absolutely. I think the first step of that is to know the law. I don't know if perhaps we could share that with our group just for them to see the text. But if they're just searching on their own, they can go to TCA 56-32-129. I'll just read a couple sentences from it. It says the managed health insurance issuer shall not discriminate with respect to participation, referral, reimbursement of covered services. That's an important key part of that legislation. Or indemnification as to any provider within a class of providers who's acting within the scope of the provider's license or certification under state law, solely on the basis of the license or certification. So translating that into simple terms, you can't say that you won't cover this service for me, that you would cover for a nurse practitioner, a physician, that I'm allowed to do according to my state laws, solely on the basis of the fact that I'm a pharmacist. That language was actually already in the code, but what the 2017 law I mentioned earlier did was add pharmacists to that protected class of providers. I think that's a key part of the code to understand. There's some nuances that we can go on to beyond that. But when you start with that basis, the next step of pursuing credentialing and contracting is to educate the stakeholders within your health system about what that means. That was my experience coming into 2018, 2019, 2020, when we really started working on this, was just to begin education first at the most senior leaders who are in operations and making executive decisions. But then one of the biggest processes for me was understanding who's who within my health system that is responsible for these various roles in credentialing, contracting, coding, revenue cycle management. That was such a massive understanding for me to understand that there wasn't just one person in charge of it all, that there is a credentialing department, that there is a coding department, there's a compliance department, there is a revenue cycle management department, and understanding who does what at what point in the process, and then having to educate those folks to what that original vision was of the ambulatory care pharmacist and what impact they can have and why this is an important thing for us to pursue. Right, because maybe that's a place to pause for a second. This takes time and money. It's not free from a time perspective to enroll with payers. It's not free from even filling out those applications, it's not free. So there is an investment, kind of activation energy that it takes to go through that process. So you need to begin with the sharing that vision casting with all of these different members to help them understand why I'm asking you to take your time and our health system's resources to help us take this step. I think things are better nowadays, and stop me anytime, Ashley, you want to go in a different direction. I think things are better nowadays than they were back 4 years ago. When we started 4 years ago, the next step after getting my side of the health system to catch the vision and understand why we're making the ask was then payer education. I can't tell you how many times I went through the cycle of teaching someone on my side, them reaching out to a target payer, them reaching out to their usual folks who are the front lines of the payer, and they don't keep up with pharmacy related law, right? That's not even reasonable to expect that this person who just credentials nurse practitioners and physicians all day, they would know about changes in pharmacy law. Well, my folks would talk with their folks, and their folks would come back and say, I don't have a drop down for that. There's not a process for me to do this. Therefore, we must not do that. And so there was this great cycle of saying, okay, that's really frustrating. There were a few times where I was like, all of the people in my health system must think I'm crazy. Am I crazy? I think that's what the law says, but I don't know. This is really hard. Um, I think what really helped was just being patient and committed to it. And what I often had to do was try to identify on the payer side who was a decision maker, who could say, you know what, this is a new law that we need to be in compliance with. Even beyond just compliance with law, sometimes that was educating on what an ambulatory care pharmacist does and how it was different from a community pharmacist. But it was key to find those decision makers, beyond just the frontline person taking the call from my health system to make the credentialing, explaining the new law, explaining the vision, and then letting them change the form, change the process to their more frontline staff in order to accept that. I mentioned that summit we were at this past week, and it was so exciting to see what was such a fight 4 years ago, where now we have reached the point where some payers, some very forward-thinking payers, are actually teaching the pharmacists what that process looks like. Whereas when it started out, we were trying to figure that out all together.
I bet that is very heartening. That gives you some energy in the middle of that. As you were speaking, it just kind of brought to my mind. You mentioned a lot of challenges, and it seemed like you were really what you're describing is advocacy, not like what we typically think of, like with our legislators, but that's advocacy in a different way. Is there something that you've learned from this, or a way that you've been able to build teams so that you're not having to go on this alone, that pharmacists are able to do this together or do this with an economy of scale?
Yeah, I don't know if I've given that a whole lot of thought, but if I can just verbally process out loud, um, I think an analogy that I've used for this process of learning is sometimes when you're the first into a space, or maybe not the first, but just an early person in this space, you're kind of a trailblazer. There's not a path out in the woods, and so somebody's got to make that path first. And so then I think a really key thing to have a trail stay or become a road is to have road pavers come behind you. And I think that has been a really key element that I've learned is necessary, is to identify the right stakeholders, that instead of saying, hey, this is a one-off thing we're doing for this really passionate guy, saying, how do we build a process and procedure that when we hire this person, they enter the normal health system credentialing process here. That normal health system process is now educated to the inclusion of pharmacists. And then this is going to happen. And just that road paving is how you turn a trail into a road, and that road is maintained over time. It's that part, everybody's personalities are different. That part is not as much of a bucket filler to me. I really like going and doing new things and fighting hard fights and trying to fight hearts and minds and blazing trails. But that is just as key and important as saying, not everybody who comes behind me is going to understand what I have learned. And if I want to have a lot of people follow me, then it's important we take the time to pave the road and make it easier for folks to come after.
Yeah, I think that's a great analogy, and hopefully we will have a highway soon, right? So what do you think? You mentioned our summit where we had a great group um, of pharmacists that we hope to continue and we hope to grow going through this credentialing process and contracting process. What do you think are some of the biggest takeaways that you learned from this first iteration of the credentialing process? Like, what are some of those tangible take-home points?
Ooh, that's a good question. I think, first of all, we've already mentioned complexity. So you need to count the costs before you go down this road and think through who are your major payers, what is your payer population, because even within the realm of payment, if you have an almost exclusively Medicare population and you have a minority state level insurance, commercial, Medicaid, you're probably going to take a different tact in your billing strategy. So it's important that you sit down and count the cost before you begin going down this road. That's maybe takeaway one. I think takeaway two is to know that what's the Peter Parker quote? With great power, privilege comes great responsibility.
Yeah, there you go.
This is a great privilege to be recognized as a provider and to be supported by our legislatures to be entitled to the same privileges as other providers. But being a provider itself comes with responsibilities. So there are responsibilities to our profession, there are responsibilities in maintaining that scope of licensure. For most of us, that's a collaborative practice agreement. So making sure you have good systems to maintain good privileging from the perspective of quality assurance for your clinical practice. And then finally, I think maybe a branch off of this idea of responsibility is understanding just how insurance and fee-for-service economy works. So patients have a responsibility when it comes to receiving medical services. And that's going to be it's true whenever they go see their endocrinologist. It's true when they go see their PCP. It's going to be true when they see their pharmacist. If you're enrolled as a provider, your patient may have a deductible. They may have a copay. They may have a co-insurance. And that's something that we as pharmacists aren't used to. We're not used to being recognized as providers to receive the payment from insurers, but we're also not necessarily used to our patients having to pay to receive our clinical services. We've given it away for free for so many decades. And so that can be a little disheartening thing if you're not prepared for it. But it's not something to discourage you. It's something to turn this around and say, you've been providing this really valuable service. And it makes sense that in the way that the economy works, you trade value for value.
Mm-hmm.
On the flip side of that, you better make sure you're providing a value. If your patient can't tell a difference in their health and their medications after a visit or two with you, they're not going to keep coming. That copay is a cost to them. And if they're not getting value for value, that's going to mean you're not going to have a successful clinical service.
100%.
So I think
and thank you for explaining that clearly. That is something that I did not have explained to me when I first started billing. So there were patients that were in their deductible, or there were patients that had co-insurance or co-pays, and I didn't necessarily explain that on the front end. And they received, EOB or whatever it may be. And I was saying this is a covered service just earlier in my career. And I was looking at the physician fee schedule and how much we would recoup. That is how much we would recoup, but that includes the patient responsibility. And so again, that's something I did not learn in pharmacy school. I learned in the real world, I guess. So I'm glad that you called out that actual fact. And also the fact that when we give away our services, what that actually means and what we're saying about the value of those services, not only to the public, but what we're saying about the future of our services, because they are worth something. They're worth a lot. And I believe that we have a sustainable business model. And so I don't think giving them away for free is something that we should be doing. That's my personal opinion. So I think that's a great thing. So the next question I have is, what is something that you would say to Jonathan 4 years ago? Like, hey, there's a roadblock up ahead. Don't do that. I wouldn't do that. Some roadblocks that you would change.
The biggest thing I would tell Jonathan 4 years ago is just to be patient.
Yeah.
And there are people telling you to be patient, and it's annoying you, but you just need to be patient. That great things don't happen overnight. Big changes take time, and it's painful during that time of waiting. I think Abraham Lincoln has a quote that I'm going to butcher it, but it goes something to the effect of government moves at the speed of people. Right. And that's the same thing for organizations. Organizations move at the speed of people. And so if you may have a strength in futurism, the ability to think ahead. But if you're not patient to wait until the rest of your team, or you're not focused on casting that vision for the people around you, you can very quickly become frustrated if you're ready to live in 2030 and people are not. So that's the biggest lesson to Jonathan. I think other lessons learned come from around the need for policies, the needs to pave roads. I think another aspect of paving roads is communicating that, hey, there's a road here. Um, hey, there's a service here, and making sure that all of the stakeholders are aware of a new thing. Because there's nothing worse than when you're a stakeholder for something and you get blindsided and you weren't aware of something. And so that was just a lot of personal leader lessons for me, is even just opening my eyes to realize who are the people in the field and who are the people in the room who need to know about something. I may have a great idea, and my one up, two up, they may love my idea, but my lateral coworkers, they, I'm gonna need them. They need me, I need them. And what I'm doing in my lane, they need to be aware of, for one, so that they can adjust and make adjustments themselves, but also so that I can listen and be humble to get advice from them on impacts my ideas may have on the rest of the health system.
Yeah, that's great. Okay, next question is kind of a more practical question. So if there's a pharmacist in the state of Tennessee who's interested in undergoing this process, credentialing and contracting, what are the requirements? I'm assuming you're a licensed pharmacist, and let's say they have a job in a clinic, or they have a clinic who's interested in hiring them. What are the other requirements?
Yeah, I think I'll get into the nitty gritty, but I think the first thing here is to think about, what is your clinical model? When I have started working with folks who want to go down this road, so often I see them trying to build the financial justification, and they're trying to answer questions about what code do I build before they even really have a well-defined clinical service model. It's and the phrase I'll use all the time is, you're putting the cart before the horse. You need to make sure that you are well equipped and trained to provide a clinical service, and that there is a need for that service, such that when you go out in the marketplace and you start offering that there's going to be people who come and who ask for that service. But so often I see people starting out from trying to figure out, well, how much money can I make using what code? And then maybe I'll figure out what clinical service I'll offer based on that. That's just not a good idea. So I always recommend having your clinical service firmed up first. Now, part of that is going to involve saying, well, what can I make the business out of? But just keep the cart behind the horse. The next step is to try to identify who are the stakeholders in your health system or in your own independent practice of actually becoming credentialed. If you work in a health system, there's typically going to be a department who handles that for the other providers. I was very fortunate and blessed to be in such a health system so that I didn't have to create a lot of that from scratch on my own. And so there was already a pathway for the other providers. And kind of the thing I kept on repeating was, we're another provider. You're not having to create another pathway for us. We don't need to have the regular provider and then the pharmacist over here. Just let us walk on your road, right? There's going to be some widening of that paved road. We're beating that analogy to death, aren't we? But we don't have to make a new road here. Just let us walk on your road. What they're going to do is they're going to take one of two pathways. One pathway is an individual enrollment or credentialing with each payer. Some advanced health systems also have something called delegated credentialing, where essentially they make agreements with the various payers to say, we're going to handle credentialing, which for those who are on the call or watching this may not be aware of. Credentialing is saying, I am who I say I am, and I know what I say I know. I graduated from this school, I have this residency training, I have this board certification. That process of verification is known as credentialing. Kind of that first pathway is, you go through that process of proving it to every individual payer. Your Blue Cross Blue Shield versus your Amerigroup versus your United. But with delegated credentialing, the health system says, we will do the verification before we add them to our medical staff. And once they have that agreement with the various payers, the payers will say, cool, if you have vetted them, then just any member of your medical staff, we will add to our existing agreements. And so that's something to try to understand if you work in an organized health system. Do you follow a pathway where they're in credentialing with every single payer? Or are you in a delegated credentialing pathway? Once you become credentialed, the next step that a lot of people forget about is the contracting. You can be a credential provider, and credential versus enrolled, all these terms get used interchangeably, just a normal conversation. but you can be credentialed and enrolled, but not have a contract. The contract is where you say, I'm going to offer this service to your patients, and you're going to pay me this much money with this responsibility, this network details, etc. And here's, just any contract. Here's what I owe you. Here's what you owe me. It is easiest in that organized health system to find a group contract and attach yourself to that just as another member of the staff. But if you are in more of an independent process, you may have to explore that on your own. And again, thankfully, going back to earlier comment, it's very cool to see some of the payers now creating those processes, even for independent pharmacists who want to come along and pursue that pathway on their own. I'll be transparent. I don't have a ton of experience pursuing, contracting as someone not associated with the health system. But that is a possibility. Physicians and nurse practitioners do that every day. Often they work with companies that specialize in credentialing and contract enrollment. That company may also handle billing and coding for the health system. And so you pay a fee to that company, and they will do the credentialing and contracting work for you. So that just maybe if you were doing this on your own and you were thinking of like a startup, that may be something you needed to count in your startup fees, was the cost of enrolling and paying someone else to help you do that on your behalf. There is always, I suppose, the possibility that you go on that pathway yourself, but I think for the average pharmacist, they would get pretty quickly overwhelmed with all of the details. I mean, these contracts and provider manuals are hundreds of pages long. So having someone who can guide you and mentor you through that process, I think, is really valuable.
I agree with you there. And in my experience with any of the outsourced billing coding for smaller clinics and things like that, if it's something new and you could have kind of a third party, this is how you do this, this, this. And once you've done it, it's kind of smooth sailing from there. But you're right. I think if anybody to kind of guide, it's great. So thanks for that. So just to clarify, do pharmacists, so they need to be a pharmacy graduate, they need to be licensed. Do pharmacists need to be board certified or residency trained or anything like that?
Yeah, thanks for pulling that out. That varies state by state. In Tennessee, our provider status law does not put any of that requirements on there. It's more has to do with the service you're offering. So if you are contracting with a payer to offer a service that you could not provide without a cloud of the practice agreement. So for example, medication management for a patient with diabetes and billing an office visit for that. Doing evaluation and management is not in the Pharmacist Practice Act of our scope of practice outside of cloud of the practice agreement. And so part of that contracting process, or credentialing rather, not contracting, but credentialing process, is going to be saying, hey, here is my CPA. I'm asking to be put into a contract or to be considered a credential provider to offer the service. Here's the backup to say that I can do that under my state scope of practice. And for clarification, operating under a CPA is part of Tennessee's state scope of practice.
Right.
However, there is no requirement from the law's perspective to be residency trained. There is no requirement from the law's perspective to be board certified. However, this is one of those details about the provider, the pharmacist's provider law in that section of the statute, as it says that this section shall not be construed as prohibiting managed health insurance issuers from including providers or classes of providers only to the extent necessary to meet the needs of the managed health insurance issuers, plan and enrollees, or from limiting referrals or establishing any other measure designed to maintain quality and control costs consistent with the responsibilities of plan. So if you look at our counterparts in the health system, like our physician and nurse practitioner colleagues, often those payers do require board certification, or they may put some requirements around the training that they want their providers to have. Currently, I have not seen that for pharmacists, but I think it's something that a pharmacist who really wants to pursue this might say, hey, I do want to go through some third-party verification of my skills in case that ever did become necessary in the future.
I think that's great advice. If people are interested, I do want to put a plug in for our primary care certificate program at University of Tennessee College of Pharmacy. I'm one of the clinical coaches for that, but we do have a billing component to that as well as a clinical component. It has simulated patients and things like that. If you've been in practice for a while and this is something you're thinking about. And we also have a part of that program where we practice pitching our services to whoever you're interested in. So that might be something if you're interested in kind of starting small and then going towards board certification or what have you. All right, so let's move on. This next question is, so if somebody was just first starting out, what's step one? What advice would you give them for step one?
Well, kind of going back to our last question, step one is determine your clinical service. I think just to kind of state it plainly, it's just a needs assessment, a needs assessment, and then a resource inventory. What does your health system need? What does your market need? The town of Murfreesboro may be different than the town of Dayton, as far as who is there providing services, what specialties are available in the area, and then taking an inventory of your own abilities. What clinical services are you trained to provide? When you go to make this case to a provider, a payer, a patient of your expertise in that area, what can you bring to the table? I'd say that's step one.
I agree with you. What are you really good at? What are your passions? And you can also use, if you're already integrated within the site, you can use some of the data analysis and see, like, do we already have A1Cs out of range? And that's one of our huge quality areas, or blood pressure, whatever, and kind of match those together. I think that's great. What do you think has been the most rewarding part of this process for you professionally?
The most rewarding part has been to see leaders within our health system recognize the importance of ambulatory care pharmacists to our health system, and then to be willing to create a pathway to create those positions and to make us a part of the team and expand us as part of the team. I would say that many of those leaders saw the vision very early, but going from 2 to 4 pharmacists or 4 to 8 pharmacists, what does that pathway look like without us going bankrupt? Going through this process has helped create that pathway. And that's also a way of giving back to the profession in a lot of ways. I mentioned I'm also a residency program director. It's important for us who may have academic components to our jobs, whether that's in a college of pharmacy, as a residency program director. It's one thing to produce a lot of supply of graduates, but to have a fulfilling career that helps you have a family and all the things that you want to do with life, there also has to be demand. And so there's some folks who pointed out that we have to be careful about putting a lot of supply on something in the market that we don't have the demand for because there's not a pathway to create. And so this is, I don't know, I hope this doesn't sound too out there, but in a way, this is a way of giving back to the profession, creating things that posterity can come behind and benefit from.
I totally agree with you. And I know really nationwide, but in the state we serve, there is a primary care shortage. That's why the Population Health Consortium exists. That's a part of our mission. And so Tennesseans do not have access to primary care. Physicians themselves will not be able to fulfill that in no way. And pharmacists are one aspect that could help fill that. And so what we're talking about really is the financially making that viable for clinics who want to fulfill that, and to help sustain better health for Tennesseans, right? So I think that's really what we all want. I think that's a great answer. Okay, so who have been your best allies? So that could be like organizations, leaders, pharmacists, biggest allies in making this process work.
Yeah, I hate to name names on an enduring product like this, but I think my supervising physician has been a key champion, and that is probably one for an ambulatory care pharmacist practicing under a CPA. That's one of the most key relationships you have to have. The level of trust that you need with that physician is very deep. But on the flip side, when you have that level of trust with that physician and they see what you are providing to their practice, they're going to become one of your biggest advocates. And they often those folks who are the supervising physician have a vision of a team-based model of care. And they also have a commitment to the health of their community and in providing that access. So for me personally, that's been one of my most key allies. Other allies, I would say those involved in population health and quality, since every day they work and breathe and ask the question, how do I take care of the health of this entire population with the resources that I have? Talking to them and showing, hey, here's a resource you have. You may not even realize you have this resource, or you may not see the way that this resource, if expanded, could meet the needs that you're seeing. We speak a lot of the same language. We can help fill this void and we can come alongside you. So anyone involved in your health system with regard to quality or population health, I think is a key ally. As you begin going down the road of operationalizing it, then you have to start speaking operations, which operations is very different than clinical and it's very different than quality. Operations is the nuts and bolts of logistically, how does this work? So do I have clinic space? If I'm going to see patients, I got to have a place to see them. Do I have auxiliary supports that I can run an efficient clinic? Do I understand how to enter a code? Here's the person who's going to train you on coding and billing for this service. And then maybe a final operational leader, kind of a branch off operations, would be compliance. Compliance are those folks who every day they live and breathe risk. And doing something new involves a certain amount of risk. And it's very difficult whenever you have someone who doesn't have the vision of the benefit, but sees the risk. They're typically going to say, we shouldn't pursue this. So it's very important that you can effectively communicate to your folks in compliance. This is the vision. This is the benefit we can bring. I see the risk. I'm so glad you're on my team to help me watch out for that risk. And if you see me heading down a pathway that involves unnecessary risk or is doing something incorrect, please save me. I will listen to you. I appreciate your role in the health system. I think that is a really key ally and partner as well. Something that I'm still working on developing, and I think I've realized just over the past year has been so important, is partnerships with payers. So I was really excited to attend a summit with a payer this past week. And I think that's something I'm looking forward to developing more over the next couple of years in my practice.
Wonderful. All right. And just any closing thoughts or next steps you'd like to leave with the audience?
I think, always advocating, right? I think maybe the next step for us is for us to continue paving that road in Tennessee. And to do so, we need health systems to catch the vision of the importance of billing as part of our practice model and fueling further expansion of jobs and from the profession. And then I love the point that you made earlier, Ashley, of creating that access in the community. So we need more health systems to come alongside us and go down this pathway so that we create that access to physicians and access to healthcare. That way we firm that up in Tennessee. We're still in very much of a sapling state right now in Tennessee. Now, we may be ahead of a lot of other folks in the nation, but I can't emphasize how critically young this sapling is. We are not a mighty oak yet, and we need other health systems to come alongside us and understand that things can uproot this sapling. If we don't grow this tree and make this a part of the normal health system, there are things that can come in and threaten. And that builds from a state level out to a nationwide level. We have been trying to advocate for provider status with Medicare for, I know since I was in pharmacy school, maybe even since you were in pharmacy school, Ashley. There are a lot of things that are barriers to making that happen. It would be an easy button, to hit that easy button and have it trickle down. I think it's time for us to not give up on advocating from a top-down approach, but I think that we also need to be exploring bottom-up approaches and working with our neighbor states to say, hey, here's what we're doing. Can we help you have conversations and give you model criteria for legislation and regulatory change so that you can move forward, such that we're not waiting on the federal government. We're moving forward at our own state levels. And my hope, nothing is known and guaranteed, but my hope is that we will reach some point where the federal government recognizes that they have gotten behind and it's time for them to catch up if our top-down advocacy efforts are not successful.
Thank you so much for that. I will say one thing while you were speaking, it reminded me, I want to just give our listeners some encouragement, because you were talking about your supervising physician being such a champion. Really, really early on, when I was first doing my very first CPAs, I was so nervous to ask for those when I wrote them. And I really thought back then, like, all of the physicians had to be on board with me. And then I got my CPAs signed by two physicians and 2 nurse practitioners at the state I was in that was allowed. And once I got the 4, my schedule was full. And so I guess the kind of the lesson that I want to just share is that not everybody has to be your champion. If you get a few, you're going to be busier than you can handle probably. And so just take that into consideration when Jonathan is saying we're a sapling. Not everybody's going to catch our vision, as he was saying, and that's okay, but we can still keep going, and our patients and everybody else is going to go out there and tell your story for you, the success for you. And so I really appreciate that. Thank you for joining us today, Jonathan. Thank you to our listeners, and we will have more material for you in our Physician Pharmacist Collaborative track here at the Tennessee Population Health Consortium and with the Tennessee Heart Health Network. Thank you so much. Bye-bye.
We hope that you've enjoyed today's webinar. For more information and resources, please visit our website, tnhearthealth.org. You can find more webinars under our resources page. You can also follow us on Twitter, LinkedIn, and YouTube. Please let us know if there are any specific topics or speakers that you would like us to present. Lastly, tell anyone you know who would be interested in helping to decrease the burden of cardiovascular diseases in Tennessee and share the webinar. Together we can achieve our goals of managing and preventing heart attacks and strokes for Tennesseans.